Good morning. Usually, ocular trauma is overlooked and underestimated, so that's why we are here today. So, why it's important? Trauma to the globe and ocular nexa remain the most common emergency room consults in all parts of the world. Studies from across the globe have prognostic poor outcome for open globe injuries. Ocular trauma is the cause of blindness in approximately half of a million people worldwide, and many more have suffered partial loss of sight. Trauma is often the most important cause of unilateral loss of vision, particularly in developing countries. The lack of uniformity in ocular trauma reporting that existed earlier prompted that the need for robust ocular trauma classification system. Males tend to have more eye trauma than females, and this is already apparent from childhood. Lower socioeconomic class are also more associated with ocular trauma. The setting of the recurrence of ocular trauma is most commonly the workplace and increasingly road accidents. Domestic accidents are probably underreported. Of particular importance in some developing countries in the occurrence of superficial corneal trauma in agricultural work, often leading to rapidly progressing corneal ulceration and visual loss. The WHO program for prevention of blindness suggests that annually 55 million of eye injuries restricting activities more than one day. 750,000 cases require hospitalization, 200,000 open globe injuries, approximately 1.6 million blind from injuries, and 2.3 million people suffering bilateral low vision, and 19 million with bilateral blindness or low vision. The impact of ocular trauma in terms of need for medical care, loss of income, and cost of rehabilitation services when indicated, it clearly makes the strengthening of preventive measures very worthwhile. So generally classified into the ocular trauma, generally classified into mechanical injuries and non-mechanical injuries. The mechanical injuries, which is open globe injuries, closed globe injuries, orbital trauma, lid and canalicular trauma. And the non-mechanical injuries, chemical injuries, radiation injuries, thermal injuries, electric injuries, ultrasonic injuries. So this will bring us to the most important part, which is the classification of ocular trauma, which is PET, Birmingham Eye Trauma Terminology, which is the international terminology system developed by the International Society of Ocular Trauma, came to be known as the Birmingham Eye Trauma Terminology System. And this is to classify the ocular trauma into open globe injuries and closed globe injuries. The open globe, then the rupture, which is caused by a blunt object, and laceration, which is caused by a sharp object. The laceration is subdivided into interocular foreign bodies, perforating entry, and there is exit, and there is penetrating injuries. Closed injuries subclassified into contusion and lamellar laceration. The eye wall, which is clear and cornea, closed globe injuries, no full thickness injuries, open globe injuries, full thickness injury. The globe injuries, usually you say before full contusion, there is no full thickness injury, generally blunt injury, and lamellar laceration, partial thickness injury of the eye wall, generally a sharp object. Now, the most important part is the ocular trauma score. The ocular trauma classification group was later formed in 1997 to address ocular globe injuries with an improved classification system. The ocular trauma scoring system devised later enhanced the prediction of the final visual outcome. The BET and OTS system have been considered as the standard for the classification of ocular trauma. In the OTS methodology, visual acuity is estimated by detecting raw points for 5 diagnostic findings from initial visual acuity. Later, we'll have example of what they are saying. In order to be able to look for a possible prognostic factor, the OTS is a number between 0 and 100 and is supposed to have predictive value for the functional outcome, corrected distance visual acuity of the injured eye. It's calculated from initial corrected distance visual acuity after the trauma. And before surgery also includes additional variables such as globe rupture or relative afferent tubular defect. So from this table, we can see that there is initial visual acuity, and we have raw points, and we have also variables. For visual acuity is more than 20/40, we give him a raw points of 1 point. And if there is a globe rupture, we detected 23 points, and with the category 1, which is less than 45. For the vision, corrected vision, 20/50 or 20/200, so we give him a 90 points. If there is a frontal defect, we detect 10 points. And category number 2 is 45 to 65 points. And to the end of the table. So we have an initial visual acuity, and we have a raw points, and we have a variables. And from that, we can give an idea about the final visual outcome. And the expected visual final best corrected visual acuity based on the sum of the raw points. So the sum of the raw points from 0 to 45, and we can say that the patient will have a no light perception 74%, and light perception 15%, and 219, 207%, and so on. So we can predict the final best corrected visual acuity. So we have an examples.
Yeah, thank you, Dr. Haider.
1 minute to stick the time, Dr. Haider, please.
I have 2 lectures connected together, so I have 14 points.
Okay, perfect.
So
okay.
We have the most important to have an examples of what we are saying. So patient with penetrating trauma with initial visual acuity measure 200 to 20/200 with no sign of RD, FNV effect, or endophthalmitis. So calculation of OTS score raw points will be as per initial vision score is 90. There is rupture, so minus 23. The total row will be 90 minus 23, so it is 65. For OTS category 3, so we can say this the patient signified that has 2% possibility of perception of light and 41% chance of vision loss above 6/9. So example number 2, patient reported with penetrating trauma with initial visual acuity measure hand movement with RD, FNV effect. Calculation of OTS will be as per initial vision score is 70. So rupture, we have a minus 23, RD minus 11, FNV effect minus 10. So the total raw score will be 26. This is called this category number 1, which is very poor prognostic. So there is possibility of 74% chance of no perception of light and 1% chance of vision above 6/9. So from OTS, we can predict the visual outcome. So there is also modification for OTS. We have the pediatric ocular trauma score, and we have the toddlers also ocular trauma scores for each age group. Also, the classification of in-globe injuries. There is many classification for for open and for closed. For open globe injuries, also classified into type of injury, the grade, visual acuity prior to surgical care, and the location of the wound, from the zone classification to 1 in 3, and also OTS category. So for type of injury, we have penetrating, we have the rupture globe caused by blunt trauma, globe penetration, and penetrating globe. The grade of ocular trauma, as we say, we have a grade 1 to 5 according to the table, and grade 6 refer to cases in which the initial visual acuity remained unknown. And regarding the zone of classification, the subgroup are categorized according to the location of the most posterior point of the full thickness wound of the globe. So for zone 1, we have the most posterior point is located to the cornea, including the cornea scleral limbus. For zone 2, which is in group 2, we have up to 5 millimeter posterior to the cornea scleral limbus into the sclera. And for group 3, with zone 3, posterior to that on group 2. For closed globe injuries are defined as injuries that full thickness defect of the eyeball. This is without full thickness defect of the eyeball. This is the cornea or sclera. There is also referred to a non-penetrating trauma. Most of injuries are accidental and can be broadly classified as occupational and non-occupational. And the classification based on the features of the globe injuries at the time of presentation, type of injuries into contusion, lamellar laceration, and superficial foreign bodies, and with mix. With the grades also based on visual acuity, 20 to 40, 20/50 to 220, and so on still to the end of the now light perception. Pupil also, we have very important positive pupillary effect present in the affected eye, negative presented in the affected eye. Also, we have zones in closed globe injuries, external limited to the pulpar conjunctiva, sclera or cornea, and zone 2 anterior segment involving structures in the anterior segment internal to the cornea. Also include posterior lens capsule and pars plicata but not pars plana, posterior segment, all internal structures posterior to the posterior lens capsule. Now we go to the history and evaluation, which is a very important part of the receiving a patient with ocular trauma. At the first point of contact with the patient, it's important to assess the patient consciousness level, details regarding the mechanism of injury, velocity of impact, point of impact, and other information relevant to associated injury should be documented. These cases can often be medico-legal. It is crucial to document details regarding to the nature and mode of trauma, time or place of the incident, number of people involved. Cross-ocular examination presenting visual acuity and vision with pinhole should be tested using age-appropriate vision chart. If vision cannot be measured using vision chart, it should be recorded using finger counting, hand movement, or perception of light based on the severity of presentation. History of following ocular trauma, open globe must be quickly ruled out. The goals of evaluation are to identify the mechanism of injury, characterize the extent of injury, and gather relevant history. Once an open globe injury is diagnosed, preparation for surgery should be made immediately. In case of significant ocular trauma and open globe injury should be presumed. Until proven otherwise, outcomes are also dependent on the time to surgery. A purposeful history can rapidly profile the injury and guide further evaluation. Any injury involving sharp, high velocity, projectile, forcible blunt trauma, explosive firework, Ehlers-Danlos syndrome are most likely to open from injury. Setting of injury, timing of injury, allergies, immunization status, and time last ingestion also useful surgical planning antibiotic choice. Evaluation require an ocular examination for visual acuity. During examination, any pressure on the eye should be avoided as it can extrude intraocular content if an open globe injury is found and characterized on examination. Preparation for surgery should precede further examination. Visual inspection must be done by pen light or slit lamp examination. Large anterior open globe injuries, zone 1 to 2, may be obviously deformed or penetrated on pen light. Small laceration can also be identified with the Cedar test, where the eye is installed with propagate, then fluorescent and illuminated by cobalt blue. In obvious open globe injury, the technique Cedar test is contraindicated. If the Cedar test result is positive, any further manipulation of the eye is contraindicated also. On inspection, any extruded intraocular tissue is diagnostic of open globe injury. The dark colored uvea frequently prolapses typically from the zone 2 and is highly visible against the sclera, while piece of vitreous are transparent and may be difficult to identify. Rarely, prolapsed crystalline lens or intraocular lens appears as well circumscribed mass incarcerated in the previous surgical wound or beneath conjunctiva. Also by inspection, blood and hyphema, dense, diffuse, I'm looking to the counter time, also suggests open globe injuries. Other suggestive findings include abnormal anterior chamber depth. And 1 minute? 1 minute, yes. Such as iris lens, the peak pupil, particularly visible since it tends to point towards the site of injury. Also, dilated fundus examination should be done at the earliest opportunity after evaluating for ephemeral effect and angle closure. Foreign body retinal attachment, posterior globe ruptures may be visualized or ruled out, although blood may be obscure the view. Alternatively, the presence of an asymmetric red reflex may be detected with ophthalmoscope if funduscopy is not available. Other techniques such as extraocular movement, confrontation, visual field testing, brightness perception, color testing may be deferred if clinical examination confirms open globe injuries after exploration is performed in the operating room. IOP should always be recorded. Gold manipulation tonometry is the gold standard and should be low IOP by suggestive of globe rupture, choroidal rupture, cyclodialysis. IOP measurement is contraindicated in suspected open globe injuries. In ocular trauma cases where ocular examination is limited, imaging studies are usually to evaluate suspected ocular globe injuries. For home message, consequences of ocular trauma. Thank you very much.
Thank you. Thank you, Dr. Haider, for the clear and didactic talk.